All right. Um, so we're gonna tackle Viro. I know you guys have kinetics coming up. So I will if I have any kinetics notes, I, we took that fifth year, so maybe I do have some notes that I can put onto the Gabe tutoring link. But no, because we had biotech, which would taught us about like insulins and monoclonal antibodies and all that stuff. It was actually a really, really good class. It was taught by, it was a really good class in terms of content because now I know a lot about like how monoclonal antibodies work and how like insulin works and stuff like that. Um, but what made it tough was that it was taught by Dr. Kerr. So yeah. So yep, yep. But in any regard, so Viro. One of the big things about Viro is that normally we talk about uh, the disease and how the
Oh,
drugs fit into the disease. In
nice.
in this case, what we are talking about is how um, the drugs fit to the bacteria. So the focus of virology is not on the drugs, it is the bacteria. So when you learn your drugs, it's not enough to just learn, oh, penicillin is this or amoxicillin does this. You have to know which bacteria it goes to. It is Virology is very driven by what you were trying to treat. Um, so if you think, oh, I took microbio, I kind of remember microbio, it's not good enough for virology, that sort of stuff. So, with that in mind, let us go over and talk about some big overarching ideas. Um, duh, duh, duh. All right. So, where we will start, just gonna move that over, make this bigger for myself. Don't need this. I need that. All right. So, one of the biggest things that you have to remember is what is a gram positive versus a gram negative bacteria. On the first exam, you're going to be asked about, cluster, cocci versus rod, or if it's a cluster or a chain or pair. That's going to be important for the first exam. But going forward, primarily the biggest indication is it gram positive or gram negative? You must know at least this. You can get away with everything else, but you have to know at least this information. So let's talk about what we can here. Um, all right. In general, the gram positive, and I'm doing a big general statement here. In general, we can group the gram positive bacteria into a couple of different categories. The first is we have our cocci. And really what this is that we have staph, uh, staph, which includes staph aureus, staph epidermidis, epidermidis, and there's another one, but I don't know if she gave it to you, staph saprophyticus. If, by the way, she didn't give you this info, just let me know, and I will skip it. Staphylococcus. The supraphyticus. The No? Okay. Then we won't worry about it. The next kind of cocci that we have are the streptococci. Um, the three that we have are strep pneumoniae, viridans, strep, strep pyogenes, and enterococcus. One of the big things about the strep bacteria is that we look at their ability for hemolysis. Hemolysis is the idea that these bacteria will break down blood and use it as a source of energy. So you might remember this from microbio, where we talked about like the blood plates using pig's blood and stuff like that. Um, Here, what we have to talk about are the uh, the types of hemolysis. So in order, we have alpha, beta, and gamma. What you should know is that gamma is gone. So on a gamma plate, you have complete uh, clear sign of hemolysis, whereas beta is partial, and then alpha is even less. So when you talk about bacteria that cause like strep throat, we're going towards ones that are going to be causing some amount of um, hemolysis. So that's all of our cocci. So if you see staphylococcus or streptococcus, you know immediately we're talking about gram positive. The rods are Clostridium, which the big one that we always talk about is C. difficile, which is the one that you always get um, from having too many antibiotics. You end up with C. diff. Um, Other ones that we see uh, less common but are still out there is tetany, which of course is the one we get like tetanus. Botulinum, which is what causes botulism. Botulinum. And I don't know if she would have given you septicum, but those are the important ones. Finally, our last ones is Listeria and Bacillus. Any questions so far?
Oh, right after Jenna, I got one.
Okay. With the bacteria, it's a good question. So when we talk about um, the streptococcus, when we talk about streptococcus, one of the ways that we differentiate what kind of bacteria it is based on the hemolysis test. So what they do is they put blood in agar and I reversed it. It's the other way. My bad. Um, they put blood in the agar and the depending on what kind of result you show tells us exactly what kind of hemolysis is going on. So the more hemolysis you have, the more that the bacteria is feeding on the blood that would be growing, that is, everywhere in the body. Um, yep, this is the wrong one. Beta is gone. Complete hemolysis. What was gamma? Coag, maybe? What alpha is incomplete, so meaning it's like 50%. Beta is complete, so you can see it's very clear all the way through. And then gamma is only partial, so maybe about 25%. And then if you have nothing, then you are not a hemolytic bacteria. So you would be something like staph, for example. What's your question? I think it was Pierre, maybe.
Yeah, it was around the same line as Jenna, like what did you mean by gone after next to the enterococcus?
Okay. Uh, sweet, 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 sweet. Um, other gram positive. Um, did she talk about peptostrepto? I don't think she did. No, I don't think she did. All right, we'll move on. All right, let's go into gram negative. By the way, if you see me write GNB or GPB, the gram negative bacteria versus gram positive, I felt the exact same way when I was in the class. It's all about how you can organize the material. All right. Just like the gram negative, we are going to divide them into rods and cocci. For our cocci, we have Neisseria, which is things like Neisseria meningitidis, and Neisseria gonorrhoeae, however it's spelled. For our rods, we have a few different broad categories. So I'm gonna move down a little bit. The first class we have are the enterobacteria. When we talk about enterobacteria, and let me just double check this before I say it. Um, um, yes. When we think about the enterobacteria, what does the prefix entero mean? Inside, specifically, we're talking about the enteral system or the intestines. So where are you primarily going to be finding these bacteria? Primarily in the gut. And that's really where we're going to be finding um, a good amount of them. That doesn't necessarily mean that they're always found in the gut of just humans. They might be coming from the gut of a different animal, and maybe it's contaminated food that you're eating. Um, in the case of like salmonella. But in any case, uh, what we have is Escherichia coli, Klebsiella pneumoniae, Salmonella, Shigella, Proteus, and Citrobacter. Under a different category, we have the coccobacilli. These are things like Haemophilus influenzae, pertussis, and then finally, the last one, so we should just note, is under gram-negative rods, kind of generally, we have Helicobacter, pylori, and Pseudomonas. Now, if you're staring at this list and you're like, there's no way I'm going to remember what is what, remember what I said. The biggest thing you can do is remember what is gram negative, what is gram positive. All right. That's the biggest thing here. Cockeye rods, yes, they're important for the first exam. It's more important for us to really understand uh, what is gram positive and gram negative. So again, just to really make this clear, staph, strep, and Clostridium, whenever you see staph, strep, or Clostridium, gram positive. Listeria and Listeria as well. Listeria should go in there. Staph, strep, Clostridium, Listeria. If it's not staph, strep, Clostridium, or Listeria, what is it? Gram negative. All right. So that should make it really easy to remember what goes where. Okay. And then it's just a matter of remembering staph and strep are gram positive cocci. If it's not staph or strep, it's not gram positive cocci. So that means that if it's gram positive, it must be a rod. If it's not Neisseria, it has to be a rod. Does that kind of make that distinction a little bit easier? Okay. All right. Focus on broad categories. Staph, strep, C. diff, Listeria. All right. Where does enterococci? Uh, Enterococcus. Enterococcus is down here. It's a type of strep. I don't think it necessarily goes there. Um, I think it's classified as a group D streptococcus, like it gets its own strep uh, grouping because it matches a lot of the streps, but I think it's different enough where it kind of gets like shoved into its own category. Um, I wouldn't be surprised if they end up recategorizing it at some point. All right. Any questions about bacteria? Again, staph strep, Clostridium, Listeria, gram positive. If it's not one of those four, then it is gram negative. All right. Let's move on and talk about drugs. When I go through and I do the when I do the med chem for the penicillins, I'll talk a lot more about, why they're different, how they're different. You guys were kind of exposed to that already. But for now, we're really just going to be talking about the broad categories, different stuff like that. Um, what should be noted is that uh, with I just want to bring up my notes. Um, sorry, 1 second. With many of the penicillins, or I should say, with many of the beta lactams, we're going to swap this out real quick. With many of the beta lactams, the general trend is that as you go up in how do I want to say this? As you go into later generations, they're more gram negative. Okay. That is the trend for the majority of the different classifications, if not all of them. I just can't think of it off the top of my head. So the biggest thing is to remember the order in which the different beta lactam groups were discovered. So the cephalosporin generations, the penicillin generations, different stuff like that. So with that in mind, this gives us an idea, depending on where it falls in its classification, are you going to be leaning more towards gram positive? Or are you going to be leaning more towards gram negative? All right, penicillins. The first category of penicillins are the natural ones. So the ones that were derived directly from some sort of fungus. Um, and for the most part, they have very limited uses nowadays because they were used for so long, and now we have just tons of resistance to them. Couple of big things about the natural penicillins. So we're talking about penicillin G, VK, uh, and I think that's it. Benzylpenicillin is penicillin G. By the way, penicillin G is IV and VK is the PO. The activity of the natural penicillins is gram positive bacteria. Specifically, these are primarily only going to be effective against bacteria that are on the inside of the body. Am I crazy? Uh, is that a good way of putting it? Kind of. What did she say? Did she give you the activity of them, or did she just give you the uses, like what they're generally for? She gave activity. Okay. All right. Gram-positive bacteria, primarily strep. Yes, if you could send me the doc, that would be great. Because I can't remember what she ended up putting there. That's fine. All right, let me grab that. Oops. Oh, yeah. I remember exactly this now. Yep. Now, now I remember. Okay. This is how we're going to do it. Whenever we look at gram-positive bacteria, we're always going to think staph, strep, enterococcus. Why are we going to look at Clostridium? Because Clostridium is primarily only going to be used with vancomycin. So we're not going to worry about Clostridium. We're not going to worry about Listeria right now. We'll just focus on these three. Where do we primarily find staph? Either staph epidermidis or staph aureus. The skin. Where do we normally find strep? Where do people get strep? Inside the body in some way. So whether that's the nose, the throat, uh, the genital tract, GI tract, different stuff like that. Nose, throat, tubes. Your nose tube, your throat tube, your GI tract tube, all that stuff. Urinal tract. And then finally, where is enterococcus? Where are we going to find enterococcus? As we talked about earlier, intestines. When we think penicillin, I want you to think nose and throat. So what is going to be useful for our natural penicillins is primarily nose and throat infections by streptococcus. So gram-positive, which strep only. Now, when we talk about natural penicillins, as I said earlier, one of the big issues with them is that we have lots and lots and lots of resistance to uh, these different antibiotics. So for a lot of them, it's not necessarily useful um, uh, to use penicillin by itself. What was developed instead, what do we want to do first? Let's talk about the aminopenicillins. So the aminopenicillins had to come in order to work on the bacteria that ended up becoming resistant to these different kinds of antibiotics. So again, the activity is on gram-positive bacteria, staph, strep, enterococcus. And so what we find is that we retain the strep activity as well as gaining staph activity. Any questions about that?
So aminopenicillin is pretty much the same use as the natural penicillin, pretty much.
Uh, in some ways, yes. So let's talk about different. Uh, did she talk about conditions at all? Like what they're used for? Or not really. I think she just went over like activity mostly, right? Oh, and it's but she did focus a lot on like pharmacokinetics, contraindications, side effects, that sort of stuff. Yeah, okay. Now I'm starting to remember the first exam. So when we think about the aminopenicillins, which is ampicillin and amoxicillin, the utility of them is that now we can cover a wider range of gram-positive bacteria. So we're covering staph and strep versus strep only. And this is why a lot of times you'll see amoxicillin used instead of just going to penicillin for a strep throat. Why? Because there's lots of resistance to these older medications. Yes. No, I'm crazy. I'm looking at the wrong thing. Give me 1 second. I think my notes are all screwed up. I think my notes are all screwed up. That's not good. Oh, they are. Okay. Well, that all got messed up. Um, Let me think real quick. How could we? Mm-mm-mm. Oh, I see where my notes are all fucked up. And we didn't talk about anaerobes, did we? Hmm. Anaerobes are on exam too. Okay. What's a better way of going over this info? If they have activity in general. Okay. All right. I have a better way of going through this info that I think will make a little bit more sense for you guys. We're going to do it how I did it during rotations. And let me go to this as well. Mm-mm-mm. Whoa, whoa. Where did it go? There it is. Fourth year, semester two. There and there. And this. All right, let's back up. Natural penicillins. For the natural penicillins, where, oh, actually, we can use the same charts that I wanted to show you anyways. Okay, we'll do that. Let's look at our different bacteria. Gram negative and gram positive. Broad strokes. This is what we can say about them. For gram positive, we have our staph, our strep, our enterococcus, and MRSA. For gram negative, we have Enterobacter, Pseudomonas, H. flu, and vancomycin resistant Enterococcus, which actually, by the way, this is gram positive, but I'll explain why in a second. So let's go through and let's compare these different drugs, and then we'll talk about specific things that we should know about them. For our natural penicillins, their uh, activity is going to be strep only. They will have some activity against mouth anaerobes. So Peptococcus, Peptostreptococcus. But for the most part, we're talking about the Streptococcus. Where we can get Enterococcus coverage is if we use them in combination with something else. Mm, yes. Okay. Because so many different kinds of bacteria were breeding resistance to them, because the natural penicillins were originally active against staph, what had to be developed was the penicillinase resistant penicillins. What these drugs did is that they recovered the ability to cover staph. They added strep, but they added staph, they kept strep, but they lost their ability to cover mouth anaerobes. It wasn't until we got to the aminopenicillins that we started to get some gram negative coverage. So our aminopenicillins, amoxicillin, ampicillin, what these drugs are doing is that they're covering strep, they're covering our enterococcus, and they're picking up some gram negative activity, enterobacter and H. flu. What's important to know about the aminopenicillins as well is that they allow us to pick back up our anaerobes. Everyone with me so far? Okay. We'll go back through and we'll talk about the specifics for all of them. In order to have even more, so one of the big issues when we talk about uh, the penicillin's ability to cover bacteria is what is one very scary bacteria that so far we haven't been able to touch? MRSA, definitely MRSA. And what's another one? Even scarier than MRSA. We can handle MRSA nowadays. Pseudomonas. So, our expanded spectrum penicillins, these guys are the ones that are covering Pseudomonas. And Pseudomonas is a killer bacteria. Uh, Pneumonia, lots of pneumonia. That's the one that kills COPD patients a lot and like COVID patients, I believe. Don't quote me on it, but I believe. Am I crazy? Um, mm, yeah, pneumonias. So when we look at the expanded spectrum, they're essentially just improved versions of our aminopenicillins. So they cover strep, enterococcus, enterobacter, pseudomonas, and H. flu. Uh, Definitely mouth anaerobes, some gut anaerobes, although you really shouldn't rely on them. They're not a real reliable option. And then finally, what we have is our uh, aminopenicillins with the beta lactamase inhibitors. Well, not aminopenicillins, just penicillins in general. These guys are like improved versions of the aminopenicillins. So for these guys, we're covering staph, we're covering strep, we're covering enterococcus, enterobacter, and H. flu. Everyone with me? Does this kind of help everybody get organized on the different info? All right. What I'm going to tell you is that this information is already written out for you in these charts. Here's the same chart that we were working on. And now they're right here for you. So what does natural penicillins cover? Streptococcus, penicillinase, resistant, staph, and strep. What I did on the exam is I literally would think of the X's and the shape of the X's. So for example, for the carbapenems, I would think, oh, it's all the way down on both. Boop, boop. And so that's how I memorized them. It also helps you keep things in perspective about, how things change as the different generations go on, right? So for example, first generation cephalosporins, uh, staph, strep, enterobacter. Then you have 3, 4, that sort of thing. Please. Um, what this means is I'm not going to go through every drug and talk about, every class and talk about what it's good for and different things like that. You have it here. What I think is more important for me to do is to go through and talk about like the clinical pearls as well as the tips and things to remember. Because I don't think anybody needs me to redo these charts because it's just going to be me, um, you know, uh, saying the same thing over and over and over again. Um, what I will say is that if you find that there's some sort of error, let me know. I'll go and I'll fix it. But I think by now they should be accurate. Um, I just can't. But if you find something, let me know. All right. Whoop, fuck. Oh, is that like gone, gone? Oh no. All right. Let's talk through the important things about the different drugs then. Really, the biggest thing when we talk about penicillins is they are um, really, actually, I should say for the beta lactams in general. Did she go over mechanism or is that medchem? I think that might be medchem. Medchem. Okay, then I'll wait. The biggest thing about them for the majority of the beta lactams is that they have really good CNS penetration. These drugs are able to get into the CNS, but what's important to know is that you have to have inflamed meninges. What condition causes is an infection in which we have inflamed meninges? Meningitis, exactly. Meningitis is just an infection of the meninges. So can you have lots and lots of different bacteria that cause it? But if you have if you do have meningitis, beta lactams are able to get into the CNS. The exception to this rule is that ceftriaxone and aztreonam are always good. So if you're not really sure where the infection is or what's going on, ceftriaxone is a good idea to get it into the CNS. In terms of elimination, primarily we're talking about renal tubular secretion. What's one of the major complications of renal excretion? What's one of the complications if you have a renally excreted drug? Right. Some sort of kidney failure. So if you have AKI, the patient is dehydrated. If you have, someone's kidneys are failing because we gave them contrast dye and now they're in AKI, or someone just has chronic kidney disease, then beta lactams can accumulate. And this is where we start to get into the danger zone of their side effects. And we'll talk about those in just a second. The exception to the renal excretion is nafcillin is biliary. So it's being excreted in the feces. And ceftriaxone and anti-staph penicillins. So oxacillin, dicloxacillin, those sort of things are biliary and renal. So that's our broad strokes. When we talk about tubular secretion specifically, what do you guys remember uh, is an issue about tubular secretion or something that has to do with kidney issues and tubular? ATN, acute tubular necrosis, right? The other thing that can end up happening is interstitial nephritis. So these drugs can induce their own AKI. All right, adverse effects. For our natural penicillins, for the most part, these guys are going to be pretty easy in terms of what they do to the body. The problem is that the manner in which they are formulated is let me just make sure before I yeah is that they can have a high electrolyte load, especially sodium. So, for example, penicillin G is formulated with a sodium counterion. So, what kind of condition do you want to be careful about giving lots and lots of sodium to someone? Hypertension and cardiovascular disease. So things like edema, heart failure, stuff like that. Since we're talking about electrolytes, what does that mean in terms of uh, if we're putting in lots and lots of sodium, we should look at drug-drug interactions with sodium. So what kind of drug-drug interactions can we have? Think about what drugs affect renal excretion. DIG, yep. Diuretics, ACE inhibitors, lithium. These are all drugs that affect sodium excretion. Do natural penicillins require renal adjustment? 100%. You have to renally adjust pretty much all of them, which is the only one that you don't have to renally adjust out of the beta lactams. Nafcillin. Why? Because it's 100% biliary excretion. Everything else you do have to worry about it. Lastly, allergies. Very important to note. When this is going to be pretty consistent across the board, but when levels of beta lactams rise, their ability to get into the CNS increases. So we see things like seizures. So in someone who has normal renal function, do we really have to worry about seizures? Not really. But over the course of someone getting their antibiotics, let's say they're on a 10-day course, what do we need to monitor over time? What's going to be the thing that we monitor in order to make sure their renal function is okay? Serum creatinine. We generally don't measure the drug level because it would be very, very expensive, where we can just measure their renal function. Much, much easier. All right. Penicillinase resistant penicillins. Um, IV, nafcillin, oxacillin, PO, diclox. Big things when we talk about the penicillinase resistant, you're going to have a lot of the same overlap in terms of, you know, what's going on with them. Um, I'm just going to write same as above. Um, Specific drug-drug interaction with warfarin. Decrease the warfarin concentration, which is going to decrease your INR, which is more clotting. All right, aminopenicillins. Amoxicillin, ampicillin. The biggest thing about these drugs is that they are um, the how can how can I put this? Mm, 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 I'm trying to think of how I can put it all together in kind of an easy way. I would say the biggest thing to note about them is that ampicillin is an empty stomach, whereas amoxicillin is with food. Does anybody know why amoxicillin should be taken with food? Even more than that, diarrhea. Lots and lots and lots of diarrhea. If there's one thing you should know about amoxicillin is that it can cause pretty significant diarrhea. Um, of course, people can be allergic to it, that sort of thing. Really, we start to see some of our kind of drug-drug interactions you might have heard of before, especially when we talk about oral contraceptives, warfarin, estrogens, which honestly we could just put here, and allopurinol. Extended spectrum. Uh, can anybody tell me, what is the big thing we have to tell patients about who are taking like Augmentin or amoxicillin? Wear a condom during that period because a contraceptive might be less effective. So when someone goes on Augmentin or amoxicillin, they should be using a secondary form of protection during that time. All right, extended spectrum. Again, this is our Pseudomonas. So piperacillin, lots and lots and lots of gram-negative activity, which is really great. Um, Usually, you're going to see this pop up with Pseudomonas. Tons of tissue perfusion. It gets everywhere in the body. So when we talk about a drug that's able to uh, when we talk about a drug that's able to get to pretty much every tissue and really have a big effect, Piptazo is the one you're going to go for. The other really big thing about this too is that we have lots of biliary excretion. And if you remember, what was our biliary excretion was our anti-staph penicillins, which piperacillin is one of them. What this means is that we're going to use it for infections where the drug is going to end up getting dumped into. So intra-abdominal. More than any other drug uh, that we talk about, Pip, Piptazo has a ton of sodium in it. So renal dysfunction, hypertension, edema, heart failure, all that sort of stuff. Um, any questions about penicillins? All right, let us talk about cephalosporins. Again, I'm going to be talking broadly just so that way I'm not repeating myself, and then that way we can kind of uh, get to the important things. Really, the biggest thing about to know about the cephalosporins for this exam is their activity. The biggest thing you're going to be asked about them is which one is going to work for a gram positive, which one's gram negative, and the differences on that is huge. All right. You have to know what generation a cephalosporin is in. So if you don't remember that cefoxitin is second generation, you need to go back and do the drug flashcards over and over and over again. Very, very important. They all have very similar names. It's definitely something you have to know. So when we talk about when we talk about the cephalosporins, in general, we can say these adverse effects. There is some cross reactivity. So it's not surprising if someone has very, very severe penicillin allergies, especially to someone who has, is allergic to multiple different kinds of penicillin, that maybe they'll have a cross reactivity with a cephalosporin. It's the rate is really low, but it's still there. One of the other things that can end up happening, and this can also happen with the penicillins, is autonomic hemolytic anemia. Essentially, the body goes nuts, and the uh, the antibodies produced against the drug end up causing the red blood cell membranes to break down. Um, it has to do with how the antibodies are sticking to the red blood cells, and then the spleen kind of gets involved and all that sort of thing. But the biggest thing is that uh, uh, cephalosporins, some penicillins can cause a drop in red blood cell count. Usually, we're going to see this with piperacillin, which is not a cephalosporin, but I'll put it here. Uh, we're going to see it with ceftriaxone and cefotetin. So these are the drugs that we might monitor their red blood count. Because these drugs are going to be working against, they're also going to kill bacteria in the gut, beneficial bacteria, we can end up getting a vitamin K deficiency in some patients, especially if they're on it for a long time. We're not, we don't want this to happen, but it's because the bacteria that produce vitamin K for us, like Bacteroides, Enterobacter, enterococci um, are killed. So this means that we would have a drug-drug interaction with warfarin and other anticoags. Why other anticoagulants? Right. Because vitamin K still has to do with clotting. It's going to be most uh it's most notable with warfarin, but there's still an ability to see an uh, anticoagulation change, maybe a little bit more bleeding, especially if someone's taking it for a long, 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 long time. More nephrotoxic effects, especially when we talk about acute interstitial nephritis or tubular necrosis, that sort of stuff. These guys are seizure inducing, which was something I saw on my rotation, especially with renal failure. And then the last thing is that a couple of them are going to cause a disulfiram like reaction. Does anybody know what this is? You guys, I think, had it on your first Thera exam, disulfiram. Exactly. So it interacts with alcohol, and then you end up having hypotension, tachycardia, vomiting, different stuff like that. Um, other kind of, I'm just kind of scrolling through just to see uh specific things. Do, do, do. Yes, acute interstitial nephritis. Yeah. Um, no, I think that's fine. All right, carbapenems. Is this helpful, by the way, to go through it like this? Okay. All right. All right. Carbapenems. A couple of things to note. Imipenem. So a carbapenem is kind of the way I think about it is that if we really can't use a cephalosporin or a penicillin, like we just want to like make sure that we're covering everything, use a carbapenem. They cover they have really, really good coverage for positive and negative. They're very, very good kind of first antibiotic to lean on. That being said, that they can have some funky things with them that we have to be aware of. Um, Imipenem has to be given with Silastat. Uh, Imipenem is broken down by uh, an enzyme called human dehydropeptidase. So silostatin is what's preventing a very specific um, uh, degradation pathway. couple of important things to note about carbapenems. They're your last resort drug. So if nothing else is working, we usually go to the carbapenems. And once we go into exams 2, 3, and 4, you'll learn a lot more about them. But you're going to be seeing them used in a ton of different things. Some of the ADRs that we should be aware of is lots of CNS toxicity. So again, seizures, especially when we have renal dysfunction, highest risk is with imipenem. Lowest risk is with meropenem. Does that mean you're not going to have it with meropenem? No. You will still have some pretty significant seizure activity. Pretty significant nausea, vomiting, diarrhea associated with them if someone is to get it. Lots of kind of GI upset, that sort of thing. And then finally, in terms of infusion, this can cause sometimes a rash. So what you would do is slow the infusion. Trying to think of the other drugs. Did you guys have aminoglycosides on your? Yes. Okay. You guys will talk a lot about aminoglycosides in um, kinetics. There's a lot of very interesting things about them and how they end up working. Biggest thing about them, and of course, these drugs are not penicillins, so we can't use the broad overarching ideas that we have before. So what's different about them is that unlike the penicillins, which have good CNS penetration, the aminoglycosides have poor CNS penetration. Um, where the penicillins were tubularly excreted, the aminoglycosides are glomerular filtration. So what's the difference there? What I mean by that, when we talk about tubular excretion, we're talking about going through one of the transporters that's along the actual uh not ureter, uh, renal tube, right? So exactly, the OAT transporter is a big one. Aminoglycosides are being filtered right at the beginning of the renal tubule. So, what is going to be one of the major ways that we monitor aminoglycoside um, activity? GFR or creatinine clearance as well. I think I think GFR is the bigger one, but I can't remember off the top of my head. It might be creatinine clearance. But essentially, what we're talking about is the filtration capacity of the glomerulus. All right, ADRs. When you have a drug that is very, very effective at killing things, you have a drug that is very, very good at causing lots of issues. What is one of the uh, aminoglycosides cause uh, a nephrotoxicity? What this means is that we're going to have ATN, necrosis, rather than nephritis, which is inflammation, right? So we're physically going to be destroying the renal tubule. So when we talk about drugs that are nephrotoxic, what can you guys remember? Which drugs are nephrotoxic? Drugs like NSAIDs, stuff like that, right? Nephrotoxic drugs. Um, uh, Lots of other antivirals, acyclovir, tenofovir, lots of chemotherapy drugs, anti-inflammatories, all that kind of stuff. Aminoglycosides, AMG. All right. The other thing about them is that their ability to collect in the vestibular uh, cause an ototoxicity, um, especially when combined with loop diuretics. The biggest thing here is that you end up getting things like tinnitus, vertigo. You're completely throwing off the vestibular cochlear ability of the ear. And so while the nephrotoxicity is reversible, you are permanently damaging someone's hearing, which is why assessing the hearing ability of someone before they go through aminoglycoside therapy can be really, really important. Why loop diuretics? What what are loop diuretics doing with aminoglycosides? Exactly. Yep. Right. Loop diuretics are ototoxic as well. All right. Other important things. Uh, Glycosides are teratogens. They are not to be used in a pregnant patient. And then they can lead to a neuromuscular blockade. The thinking behind this is that the it messes up with the ability for the muscles to utilize certain um, ions, I believe, like magnesium, uh, possibly calcium as well. So one of the conditions that we've already talked about in which this would not be useful is in myasthenia gravis. Where's oh, there we go. Any questions so far? All right. Vancomycin, um, the it's renally eliminated. So when we think about vancomycin, we also have to think about their uh, the kidney function of the person. The uses of vancomycin depends on the route that we administer it. So whereas other drugs can tend to have a lot of the same activity depending on where we're using it, uh, vancomycin has very, very, very different uses. It's primarily going to be used for gram-positive bacteria. When we think of this, MRSA, Enterococcus, uh, um, Staph epidermidis, all that sort of stuff. What do we use oral vancomycin for only? Good guess. C. diff. Does anybody know what the bioavailability of vancomycin is? I believe, yeah, it's about 8%. So what this means is that almost no oral absorption. So we can only really use it for drugs that are, or sorry, for bacteria, gram-positive bacteria in the gut. So what is that primarily going to be? C. diff. So the only use you should ever pick for oral vancomycin is C. diff. You should never, ever, ever. Uh, Oral vancomycin doesn't work for anything else. IV vancomycin works on MRSA. It works on vancomycin. No, that's the reason why we have Viro E1. C. diff only. A couple of other important things to note is with vancomycin, we have to watch the trough level. We have to watch the levels of vancomycin inside the body. The ideal trough level is 15 to 20. This is a level that you need to know. You have to know that we're looking for 15 to 20 milligrams per kilogram, Q, 8 to 12 hours. You must know this. All right. Adverse drug reactions. One of the things that happens with vancomycin is that we can end up having nephrotoxicity. Primarily, this is due to a too high trough level. So the amount of vancomycin is above 20 milligrams per kilogram. What is the solution if you have nephrotoxicity with vancomycin? What are we going to do? No clue what you guys are jammering on about. Why lower the dose, right? So if we are giving them, a certain dose of vancomycin, what we're going to do is the next time they're due for a dose, decrease it. And what you guys will learn in kinetics is how to calculate that dose. Of course, when we talk about these sorts of drugs, we also have to talk about ototoxicity. Again, this is associated with too high of a level. Usually this is for a extended period of time. So the first two have to do with the levels of vancomycin. The next has to do with how quickly someone is getting it infused into them, called red man syndrome. Essentially, what this means is that when someone is getting a bag of vancomycin, usually we infuse it over the course of an hour. So if they're getting 500 milliliters of vancomycin, then we would try to push that through into their body within an hour. What can happen in some people is that this high infusion can cause them to get hypotension, facial flushing, that sort of thing. So the solution to that is just to slow the infusion. So maybe we do it over 2 hours, maybe a little bit longer, something like that. So if someone is getting red man syndrome, hypotension, uh, facial flushing, this is not a reason to discontinue the drug. This is not a hypersensitivity reaction. That being said, people can have hypersensitivity to it, and that would be a rash. How do we know if someone's having a rash or red man syndrome? Um, Itchiness, yeah. Generally, it's not just red, right? There's some sort of other symptom going on, right? The other thing too is that if we slow the infusion, the rash isn't going away, right? The next time we do it, it comes back or it gets worse. So when we talk about monitoring vancomycin, what are some kinds of patients in which we would have to have more specific monitoring? Who would need to be watched more closely if they're getting vancomycin? Renal insufficiency. Yep. Uh, Hypertension, kind of. That's really only an issue. What? Oh, I missed one over here. The last one is neutropenia. So a drop in white blood cell count. This is due to long-term use. Immuno Immunocompromised, definitely. Loop diuretics, yep. Also, obese patients. Why do we need to be careful with obese patients? How do we dose? Wait, right, 15 milligrams per kilogram. Actually labeled this wrong. The dose is 15 to 20 milligrams per kilogram, and the trough level is 15 to 20 micrograms per milliliter. Same number. You must know these. Must know these. All right. Next up, we have linezolid, which is kind of like a home version of uh, vancomycin. What I mean by that is that linezolid has kind of, sort of, a lot of the same indications that vancomycin does. Dapto. Oh, did you guys get those as well? Yes. Yeah. What are those? The lipopeptides? Yeah. So for linezolid, the biggest thing is that it's like a home version of Vanco. What do I mean by that? Oral Vanco is C. diff only. Oral linezolid is broad gram positive. So someone who needs to go home on vancomycin worth of coverage could potentially go home on linezolid with it, or tadazolid is another one, although they're both very, very expensive. Really, what we are going to be using linezolid for is for multi-drug resistant gram-positive infections. So we're talking about MRSA and especially vancomycin-resistant enterococcus. You're not going to use this for a simple staph infection. Only 30% renally excreted. And another thing we should have is good CNS penetration. Adverse drug reactions, because it gets into the CNS, we're going to see issues with uh, uh, we see issues with how it interacts with um, things like the nerves uh, and throughout the body. So what we can have is optic nerve changes. So someone's vision changes, not because of an issue with the eye, but because of the issue with the transmission in the brain. Peripheral neuropathy. And then one of the things that ends up happening is that we end up getting serotonin syndrome. This has to do with the fact that linezolid is a weak MAO inhibitor. So if you guys remember, MAO is responsible for breaking down certain neurotransmitters, and one of those neurotransmitters is serotonin. So what can end up happening is that the levels of serotonin can rise over time. Because of this, what kind of drug-drug interactions would we have? Yep, MAOIs, SSRIs, SNRIs, stuff that raise serotonin, triptans for all that sort of good stuff. Um, One of the things that can end up happening with linazolid as well is called pancytopenia, which is essentially that you have broad bone marrow suppression. What does this put someone at risk for is other much, much more dangerous gram-negative infections, right? So if we give them linazolid, great, we're giving them a drug that's covering gram-positive, but then if we get rid of their bone marrow, so that way they can't produce any white blood cells, we might give them a gram-negative infection, especially when they stop the drug. So decreasing white blood cells, decreasing red blood cells, and decreasing platelets. So your ability to clot goes down, you develop anemia, that sort of thing. The good news is that usually this is reversible within 2 weeks. So we would monitor you for about 2, 3 weeks just to make sure that you get through it, and then usually you're fine. Uh, you guys got Dapto? Yeah. Okay. Is it a lipopeptide? Yeah. Daptomycin, again, kind of an alternative to vancomycin. Um, Really, its use is that it works on MRSA. Um, the As well as VRE. So if you develop a bacteria that is resistant to vancomycin, then we can give daptomycin or we could give linazolid. So of course these are kind of last line drugs. Um, Renally excreted. Uh, Kind of a renally excreted. Really, the biggest things with daptomycin is that it can be toxic to uh, domyolysis. Uh, can end up being toxic to the muscle cells. So you end up with rhabdomyolysis, which of course we know can lead to an AKI, which will lead to a rise in daptomycin levels, right? So what's some of the things that we have to worry about with daptomycin? What's one of the drug-drug interactions? Statins. Does this mean that someone has to be taken off of a statin if they get daptomycin? No, only if they are at risk of it, right? If they've had rhabdo in the past, something like that. Kind of on the lower end, I should have written this above. So put this there, is reversible myopathy. So, pain in the muscles, that sort of thing. And then some people develop what's called allergic pneumonitis, which is inflammation of the pneumothorax. Um, so it's your lungs are inflamed. So it it essentially it feels like your lungs hurt all the time. That sort of thing. Last thing I want to say. Oh, big thing to know about daptomycin. Skin. We use daptomycin for its ability on the skin. So daptomycin is the improved version of well, it can be used in bacteremia and endocarditis, although what I've usually seen it indicated for is uh, skin infections. Well, it's IV because we're using it for MRSA and VRE, right? So we don't want to rely on someone's we just want to get the drug into the body, right? A lot of times too is that we want to be able to attack the bacteria that might be trying to infiltrate around the body, and doing it like topically wouldn't necessarily work, if that makes sense. Yeah. Um, Trying to think if there's anything else really to go over. I think that's primarily it. Um, mm, mm. All right. So we're at the end of the first session. So where are we going to go from here? Uh, what I will tell you, yes. What I will tell you is that spend today, tomorrow, before the next session, going over the activity. Don't come to tomorrow's session without practicing the activity of the drugs. You have to know the activity of the drugs. Tomorrow we're going to do a lot of work where I'm going to give you an give you a bacteria, and I'm going to expect you to be able to pick out which antibiotics will work for different things. All right. We're also going to talk about, you know, all right, I give you staph in a renally insufficient patient. What are you going to choose? Okay, this. Um, all right, you gave someone uh, a you gave them oxacillin. Now it turns out it was actually MRSA. What are you going to give them instead? So we'll talk about these kind of these different combinations and stuff like that. Um, I'll record for the medchem portion. It's really not that bad. I was taking a look at it. Um, but big thing is to know the spectrum of the different drugs. Um, oh, this slide, this page. The way that this page works is that uh, you have the different spectrums here that come from the memorization charts. So what you can do is you can randomize this order, and then you can practice and say, okay, natural penicillins, that's streptococcus and enterococcus with combo, that sort of thing. Metabolism is definitely important with the drugs. What I will tell you is that they're primarily all in the same place, but I'll talk about that during the recorded session. And if you guys end up having any questions, let me know. I think you guys have kinetics on Tuesday, Wednesday. What day is Viro? Thursday. Do we want a session Tuesday or Wednesday? What would you guys prefer? They're dropping a triple double. Wednesday is do Wednesday. So we'll do Sunday, Monday, Wednesday, and you guys will have Tuesday night for kinetics. Okay. All right. I'll make changes to the schedule. Michael, I have no clue what that means, but I think it helped, so I'm glad. Um, if you guys have questions, let me know. Um, and I will see you tomorrow.
Thank you, Gabe.
Take care.